My name is Sarah. I'm an outpatient therapist here at CADD Child under Western Behavioral Health. Autumn is my graduate student intern this year, and we're presenting today on clinical approaches and services offered here, specifically at our CADD Outpatient Clinic. So this is our child and adult clinics. We will review evidence-based models of treatment that are offered at both. However, since I primarily work with child, a lot of the case examples and things we're going to discuss today are more related to what we're doing at child. But I know that I have fellow colleagues on the call who work at adult as well. And so if there are questions specific to the adult clinic, I'm sure my colleagues would be happy to help answer anything I can't. And I also would like to kind of set the scene that this is more of a discussion. We have some information to present to you, but especially if there's other clinicians on the call or people with questions that come up related to the information we review, please feel free to ask questions. And I'm going to ask that the moderators help, if anybody asks a question in the chat to feel free to interrupt us and let us know. Okay, so Autumn's going to start us off.
All right, hi.
I'll start with learning objectives. So today we have 5 learning objectives for this talk. We're going to review research and evidence-based practices for the autism population, specifically in the outpatient setting. We're going to also review maybe some gaps in the research and point that out. And then we're going to review resources for professional development, consultation for clinicians, and where to also get access to the most up-to-date research that's happening. We're going to review the clinical services currently offered at our child and adult clinics, as we said. And then we're going to have a discussion around clinical accommodations and skills to consider when working with an autistic client, which my hope is that will be a nice discussion point as well. And then considering when to consult or refer to an autism-specific provider. So often the dialogue within Western between departments is, okay, when do we need to get CADD involved? So we're going to discuss our thoughts on that as well. Okay, take it away, Autumn.
All right, yeah. So to kind of get us started, I did a little bit of a background or literature review to kind of get oriented to some of the evidence-based models that we use in treatment for autistic individuals. So the purpose of this review is kind of to explore the current treatment available in outpatient settings. So much of the research shows that there's effectiveness of evidence-based models of treatment at similar rates for individuals with autism as there are with individuals that are neurotypical. It kind of explores like the core symptoms of ASD. They've been identified as social, communication, and then restrictive and repetitive behaviors. So just kind of keeping that in mind as far as like what the evidence-based practices are exploring. That's we'll kind of talk about some limitations to that on the next slide. But yeah, so there have been evidence-based practices that have been found to be equally effective in treating anxiety and depression in autistic individuals as in a neurotypical population. And they're listed below. So kind of to explore a little bit about like what was done in the literature review or the research that was examined, we were looking at evidence-based interventions. So ABA is autism specific. There wasn't a lot of information regarding its effectiveness in treating neurotypical individuals as far as treating anxiety or depression. But we listed it because some principles of ABA are used in an outpatient setting when treating specifically autistic individuals. Evidence-based practices found to be effective is also CBT, PCIT, social skills training, prompting and reinforcement, and then video modeling and video supports. The literature review also has other evidence-based models, but these that we listed are ones that we're specifically using at CADD Outpatient. You can go to the next slide. So to discuss a little bit of the limitations that were found in the literature review, limitations to research on evidence-based models. The research tended to focus primarily on child and adolescent populations. There's not really that much evidence or research exploring the effectiveness of evidence-based models for treatment in an adult population. So one study even pointed out that of 972 studies, only 45 looked at individuals with an autism diagnosis, ages 19 to 22, or even an adult population. That was the only population, age population mentioned. Even though there is some literature and research available that addresses evidence-based practices utilized in an autistic population, the continued research is necessary to explore how evidence-based practices are applied in an outpatient setting. There was honestly limited information or research available that looks at kind of comorbid or co-occurring diagnoses of anxiety and depression in an outpatient setting and how that plays a role in treatment.
So we put together just a list of different resources that can be useful in guiding professional development, guiding working with families. So researchautism.org has a nice comprehensive way to view current research and most up-to-date research on evidence-based treatment. Then, of course, we have our partners at the University of Pittsburgh, the REACT Lab. We have ourselves, the Center for Autism and Developmental Disorders through UPMC, Autism Connection of PA, and then ASSERT. So these are common places to find a slew of resources. So I'm going to introduce specifically our outpatient team. And I thought it was important to take a moment and identify that all of these people make up our child and adult outpatient clinics and work day to day with our population and do wonderful work. So I appreciate all of you. Services that we provide through CADD Outpatient include individual therapy, family therapy, parent support and training, group therapy, diagnostic evaluation, psychiatric medication management and nursing, care coordination, as well as teaching and consulting with other providers. So we have a big footprint as far as collaborating with the University of Pittsburgh and working with student interns in graduate level programs, the LEND program, for example, the PIT OT program as well. And Autumn's a good example of this and how we collaborate with students as part of our work here in the outpatient setting. Something that's not on this list that I want to point out is, in a way, ABA specific therapy. So ABA is applied behavioral analysis, which I'm sure the majority of people on this call understand that. And typically when, families and stuff are referring to ABA or providers are referring out for ABA services, they're referencing something called IBHS, which is Intensive Behavioral Health Services, or wraparound as it used to be called. And it's a specific behavioral model for treating the core symptoms of autism that we identified earlier. Now, there are principles of ABA that we often use in our outpatient setting. So things related to prevention strategies, positive reinforcement, how to teach skills, that kind of thing. And we use specific evidence-based models and manuals for that type of work. One example is the Ruby manual for a parent training approach. So there is ABA, versions of ABA sprinkled in within our treatment in the outpatient setting. However, it's not the traditional version of ABA that we think about when we think about IBHS and specific like wraparound providers or center-based providers using ABA. So the evidence-based models that we use in our outpatient clinics overlap a lot with evidence-based models that we use in other outpatient clinics within Western behavioral health. Things like cognitive behavioral therapy, dialectical behavior therapy, acceptance and commitment therapy, exposure response prevention, and then general supportive psychotherapy or psychoeducation. And I want to point this out because one of our points that we're making today is that there may be some cases or people who are autistic, but also have other comorbidities that are bringing them into treatment, such as depression or anxiety, where they can be effectively treated with their current treatment team and not necessarily need a CADD-specific provider or an autism expert per se to make progress in that treatment. So that was what we found with our research review, but then also that's what we find anecdotally and clinically when we're working with our population here at the clinic. So more unique to CADD outpatient are some other services we offer that are different would be some of the accommodations and things we do in PCIT. Now, PCIT is parent-child interaction therapy, and it's a model that's used in other outpatient settings and other outpatient populations as well. But I know that we've consulted with providers around if there are specific accommodations to make for a child on the spectrum who's going through PCIT. Sometimes that's useful. But there's also, we found that we can use traditional PCIT as well with a lot of kiddos on our, that we work with in our clinic, and it's just as effective. Then we have the EASE model, which we as a clinic just got recently trained in EASE by Carla and her team. And I know myself and a lot of my colleagues are already using that model. It's a mindfulness-based plus a cognitive behavioral therapy approach to treatment. And we've been finding it really useful. We do parent management training, which again is a lot of the times we're using the Ruby manual as the curriculum for that service. And then we have our groups. So we have social skills groups, a regulating together group, which is an emotion regulation outpatient type of curriculum, and then our caregiver skills training group, which is another type of parent training approach, but it's in a group setting. Whereas the parent management training is one-on-one with a family, with a clinician and a family or caregivers, and CST is in a group setting with a clinician. So we're going to go into more detail about a couple of these, the social skills groups and the caregiver skills training groups specifically, but I just wanted to point out that there's a lot of different models that we're using, a lot of different evidence-based models, and then a lot of the same models that are being used with other populations and outside providers or other departments as well. So one problem that I think as clinicians we're all aware of, especially post-pandemic, is wait lists for the more intensive behavioral health services are very, very long, and people are having difficulties accessing those services. So how are we addressing that issue? Well, a lot of those kids end up in an outpatient type of setting for care. And so we're going to talk about some ways that we've been able to successfully support people in this level of care, either while they're waiting for more intensive services in the home and the community or school, or in lieu of that. So one way we support people is through our groups. So PEERS stands for the Program for Education and Enrichment of Relational Skills. It's an evidence-based social skills curriculum that was developed at UCLA by Dr. Lageson. The way we provide these groups the way it was meant to be provided. There's no, alterations that we make to the curriculum or anything like that. We run it as a 14-week long group that's 90 minutes once a week. And we enroll teens who are socially motivated. These are middle school and high school age teens that have issues making and keeping friends. And there's a parent component for the group. So something I didn't point out that I want to point out on the previous slide is everything highlighted in purple involves caregiver involvement in the treatment. So a lot of these curriculums and evidence-based models that we're using in our outpatient facilities specifically involve the caregiver and are more effective that way when the caregiver is involved. And peers is one of them. So there's the parent group that's run simultaneously as the teen group. There's therapeutic homework every week. We do what they call behavioral rehearsals, meaning practice of skills during the group sessions. And then there's just some of the topics we go over in these groups. There's a different topic each week are things like two-way conversation skills, having get-togethers, handling bullying and teasing, changing a bad reputation. So this curriculum was developed to meet the need of adolescents on the spectrum who were traditionally categorized as higher functioning or higher verbal, because some of the research was showing that population specifically was having more issues with depression and anxiety related to social rejection or peer rejection, including higher rates of suicidality and depression symptoms. So this curriculum was developed based out of that need, and we have found in our use of this that it supports that specific cohort of people rather well, and that they make improvement over the course of treatment. It's effective. So eligibility for our groups, this is how we run them. And we are running a young adult version of peers in our adult clinic now as well. But we typically separate them by age. Middle school is 12 to 14, high school is 15, 18, and then our young adult group is 18 plus. We look for average or above average IQ. It doesn't mean that teens with lower IQ can't benefit from peers, but we would run a separate group with that, because we would then make some alterations to the group curriculum. For example, slowing down the material that's being presented. So each week, the way this format of the group sessions run is it's heavy on instruction. So there's a lot of information that gets reviewed verbally week to week, and then the expectation of practice in between sessions. So we would just slow it down if we had a group with teens with lower cognitive abilities or capacity. We do look for social motivation, and with the people that are enrolling in the group, this isn't a group that we force teenagers to enroll in. And we have a discussion with families about the importance of social motivation and doing something like this when the teen is ready and wanting to socialize more and make friends. Because there's just the general consensus that it's not ethical necessarily to force somebody to socialize if that's not something that they want to do. We don't require an autism diagnosis to enroll in these groups. So I think that is something that hasn't been communicated clearly in the past between Western behavioral health providers. Is other kids that can benefit from this are often kids with ADHD and social anxiety, and or autism or comorbidity of those three things. So if you have a kiddo who has severe ADHD, for example, and then is having some social difficulty because of that, they could benefit from peers as well. And then we require the parent commitment as well, since there is the parent group.
Sarah, you just got a question in the chat about evaluations. Do you want to answer it now or wait until the end?
Sure. Yeah.
Okay. The question is do they need to have a CADD evaluation first, or can they have had an evaluation elsewhere to be referred to these groups?
They can have had an evaluation elsewhere. They don't have to have an evaluation through CADD. If it's another department within Western behavioral health, for example, and they had a PEF over at the general child clinic, then we can use that PEF as well. But we do our own group intake meeting. So we will talk with the family and meet with them and talk about the group specifically. But yeah, they don't have to have a diagnostic, like they don't need an ADOS evaluation to enroll in group, nor do they have to have an initial evaluation with us necessarily. And if any point I speak out of turn, I know my supervisor, Lindsay Rose, I believe is on the call, and other colleagues of mine through CADD. If I say something wrong, please feel free to correct me. Okay. So this is some data that I thought was interesting to share. So we've been running the peers social skills groups now at CADD Child since 2018. So this is data over the last 5 years, used with 57 clients, where we do a pre and post measure. We have parents fill this out. It's called the SRS, or the Social Responsiveness Scale, which is looking at common symptoms and things related to social difficulties related to autism. So as you'll see, from pre-intervention to post-intervention, there's a significant decrease in the total T-scores for this scale. So it didn't, on the right side, it explains the different ranges. So when you look at the SRS, it'll say for potential autism symptoms, it'll say mild, moderate, or severe range. All of our clients pre and post were within moderate, and it didn't change range, but it significantly decreased within the moderate range of symptoms. So we wouldn't necessarily expect it to even change in range, because this is more of a scale, I believe, that's used more for diagnosing, screening and diagnosing, and not necessarily, improvement in symptoms over time, although it is commonly used in research to track that and look at that, which is why we used it. But it is telling that all of our clients decreased. Another caregiver group that we just started running is caregiver skills training. It's a curriculum that's developed by the World Health Organization for families with children with developmental delays or disabilities. It's meant for more newly diagnosed kiddos that are under 7, typically. So preschool aged kids, and it typically comprises of 12 sessions, including 9 group sessions, and then 3 what we call home visits, which we've been doing virtually as one-on-one meetings with the families. And each group session is 90 minutes. I can give more information about this if there are questions about it. But I want to say that I think we're about to run like our 5th round, and we've run half of those rounds have been virtual. So we found some success in using this in lieu of families who can't access IBHS and they need somewhere to start, right? So it's a nice introduction to what does it mean that my child was just diagnosed with a developmental delay, and how do I work on things with them like language development, daily living skills. And then another part of this curriculum I really like is there's a big emphasis on emotion regulation and self-care for the caregiver. So we start off every session with a mindfulness exercise and really drive the point home that the caregiver's first priority is to take care of themselves and their own well-being in whatever ways they need to, in order to be able to support their children. So it builds confidence in them, I believe, in understanding what to do next or what to work on, and then also how to take care of themselves and their family. So I want to share 2 examples of cases that I worked with where they were recommended more intensive behavioral health services like wraparound, or even family-based. And then while they're waiting for services for whatever reason, couldn't get access to those services, they ended up working with me. And I supported them with parent training. So the first example is a 6-year-old who was adopted and lived outside of Allegheny County. And I believe that was one of the main barriers to accessing IBHS, was because they were outside of Allegheny County, where there were fewer services provided. And this kiddo had just been diagnosed with autism and ADHD and had a prior diagnosis of ODD and separation anxiety as well at 6. So a lot going on. And I started working with the family and did virtual parent training sessions. So I met with the kid, with the family, one time for the initial evaluation, and then the following sessions were with caregivers only. And I used the Ruby manual, which again is it's an ABA approach. It's a behavioral theory approach clinically, and it goes over things like prevention strategies and coming up with a positive behavior support plan for the child and the family to implement at home and in the community. While we were working together, we also ended up connecting the family with psychiatric medication management through our clinic to target ADHD symptoms, and this family found that very helpful. So over 8 months of treatment, which was 22 sessions, we were able to successfully discharge, meeting goals to decrease elopement, aggression, and improve functional communication. And then I think the biggest improvements, as we see in a lot of these, is decrease in parental stress, increase in parental confidence, and improvement in the family relationships, including communication between the parents. So this was an example where both parents participated on some level in treatment, and they found it really useful to be able to be more on the same page in how they were parenting their child. So this was one of our success stories. And I think some of the main things that were really helpful was Ruby, coming up with that positive behavior support plan that then they could share with other people on their team, like school, other doctors, providers. Lots of psychoeducation, a lot of normalization, like what is normal for child development, right? Versus what is something we need to consider that this might just be a different way that he thinks or behaves. And then self-care and emotion regulation for the parents as well. Another example, a 16-year-old, autism, nonverbal, very medically complex. He has cerebral palsy, mostly in a wheelchair, has breathing treatments, home health nurses that aid in his care. His family ended up with our clinic after IBHS was recommended because he was having a lot of aggression, like throwing things or pinching or swatting at people, and some self-injurious things as well. I ended up doing a Ruby again with this family, provided virtual parent training sessions, also connected them with the triple board clinic, which was a very useful relationship with this family. And over 21 months and 26 sessions, we successfully discharged after meeting goals. And a lot of it, again, had to do with improvement in parent confidence, decrease in parental stress, and improvement in the parent-child relationship as well. So something that I think these cases demonstrate is the importance of including parents in the therapeutic plan and treatment, especially when we're working with this population. And it just shows like how much positive change can occur by simply educating and supporting the caregivers or the family that's involved to just better understand what's going on with their child and support them. So as more and more individuals are being diagnosed and requiring therapeutic support, let's have a discussion around maybe some accommodations to consider clinically when you're working with an autistic client. So I put these in different categories, and this is information based on my clinical experience, as well as clinical experience of my colleagues. So I just want to say that, this isn't based in research necessarily, but just more anecdotally. And so I would love this to be like a discussion and people to bring up comments or ask questions as we go through this. So the first category I thought of was communication. So generally, when we're working with somebody on the spectrum, we often give more time for processing information, especially verbal information. We'll often use less words to get points across, or use more direct communication, so avoiding idioms or analogies, which I think in our field we tend to lean on analogies a lot. And sometimes they can be useful, but sometimes it needs to be more direct. Often restating questions in alternate ways, especially if we're unsure they're hearing us correctly, or what we mean to say. Encouraging them to communicate with us when they don't understand. So I like to normalize this a lot with my clients, that I might say something in a way that doesn't make sense to you, and that doesn't mean there's anything wrong with you. That means I need to say it differently. So if you don't understand something I say, tell me, and I'll try again, right? So I try to keep that open, because often our clients have differences in how they communicate or their thinking patterns. And that doesn't correlate necessarily with cognitive capacity or level, but they tend to get talked to as if it does, right? So internalizing the message from other people that they're different and that different is wrong. So I like to open up the space in sessions and really take that idea apart, that communicating differently isn't wrong. They're still the experts in their own experience, and they have a lot to say about it. So keeping that open. But being aware of concrete thinking and learning patterns, and sometimes using that to our advantage. So we might explain things in a more black and white way to start off with, to get a concept across, and then work from there. They may have differences in expressing or talking about emotions. And again, not different isn't wrong, it's just a different way, right? So we have to be the ones to meet them where they're at in understanding what they mean when they say they're feeling this way or that way. So learning the person's language and then using it to teach and explain. Visuals are often helpful. A lot of our kiddos are visual learners, or it's just helpful to see it or write it down. So that's a tip that we use a lot. Things to consider with processing is that, in my clinical opinion, I think it's very important to have psychoeducation and disclosure about diagnosis. Especially with kids, I get a lot of families that will ask me about, well, when do I tell them they're diagnosed, or do I tell them, or how do I do that? And I always lean towards honesty is better, right? So not hiding things from them. They're smart anyway and going to figure it out. And so if we just let them figure it out on their own, then they're going to come to their own conclusions about it, which may be worse than the reality. So lots of psychoeducation and continued conversations about what does this mean, and what does this mean specifically for you, right? With processing, anytime we're working with our clients, whether we're doing CBT or PCIT or a group, we will slow down the pace in sessions as needed. And we will expect progress to be seen as quote unquote slower, maybe compared to people without autism. So often, we have to have repeated introductions of concepts or practice of concepts. but in general, it can be slower progress seen, at least how it feels to us, right? So that's something that clinically a lot of us experience. And I think sometimes it becomes a barrier in treatment because sometimes it then turns into clinical decisions being made to transfer care because they're thinking the care is not effective, when in fact it is. It's just taking longer, and it's normal that it takes longer. So I think the more clinically that we can hear, like, it's okay that it's taking longer, it's still working, and to keep up, the better. Because as we know, rapport is the most important part of treatment. We'll often see emotional reactivity in sessions. Sometimes that requires more in the moment processing or just like pausing, figuring out what's going on. This can be a real strength in treatment, is our clients tend to be more honest and direct about their thoughts and feelings. There's less masking or alternative motives for saying certain things certain ways or in front of certain people. There's just less of that. And so I find that really useful in a therapeutic setting, because honesty is key in making progress. And so that's a real strength. I see it. I use a lot of normalization with our clients because, again, like I said earlier, they tend to hear a lot about what is different or bad about them and then internalize that message. And so the more they can hear, like, hey, that's like a human thing, and also being neurodiverse is human. So hearing that message repeatedly can be helpful. Hands-on practice can be helpful too, instead of just talking about it. When you do have opportunities to practice it in session, to do that. Practice of perspective taking can be really helpful. So I think it's a misconception sometimes in the general population that people with autism can't empathize or can't take the perspective of somebody else. And clinically, what I find is that's not true at all. They can do it. It's just they're not always automatically doing it in that situation until they're reminded or prompted, like, oh, yeah, what is the other person feeling in that situation? What is that other person's intention in the situation? And then going from there. So we often use things like role play videos, examples from TV shows, and it can be helpful to have our clients identifying emotions or intentions or perspectives of others, starting with that first, before reflecting on their own experiences in their own life where they have a role in it, right? For processing, it's important to allow stimming. So stimming can look like a lot of different things for a lot of different people. I put some examples that I came up with just from my experience of pacing, fidgeting, throwing, rolling, coloring, rocking, tapping, repeated vocal noises, humming. So I've had plenty of sessions where, we're talking about things together and the kiddo is pacing back and forth and throwing a ball up and down or knocking it off the wall or avoiding eye contact. And that's something I allow. I'm not trying to subdue or correct that behavior at all. In fact, because I find it when they're doing that, it's very helpful in the processing of the information that's being discussed. So yeah, comfortability with eye contact. I like to empower our clients to advocate for what they need related to that. Whether it's in social settings like, hey, I just don't feel real comfortable making eye contact. So if I'm not looking at you, it's not personal. It's just something about me. And then in the therapeutic setting, allowing that as well, like not forcing them to look in your direction. And encouraging communication about what they feel like they need to feel comfortable in the moment to process or to continue to participate in the session. So session accommodations that we often make. A big one is transition. So transition in and out of session can look different for different people. I often allow longer time for transition in and out, warnings before sessions will end or expectations around time. A lot of my kids will check on like how much time we have left and things like that. And they're very comfortable doing that because I allow them to do that. And also teaching them like, hey, it's normal to need some kind of decompression time or something after therapy. Therapy can be draining. There's a lot of social expectation in therapy. You're put on the spot. You're expected to talk about yourself. And it's a one-on-one. It can be very intense sometimes. So what are you going to do to decompress after therapy today? Is a question I'll ask. Or what are your plans later? Like, so to get them kind of thinking like, how am I going to relax? How am I going to take care of myself? Some of our individuals can be really rule following, and sometimes they respond well to the use of that as an intervention. So sometimes I've even written like fake prescriptions. Like I'll say you have to do 10 minutes of yoga a day, and I'll write it on like a little post-it note and be like, this is your prescription, right, from your talking doctor. And sometimes they really grab onto that and like that. And it's a nice visual reminder as well. Breaking things down into steps, including treatment goals. So trying to keep things more practical, one step at a time, using special interests to encourage perspective taking, as well as talking about their special interests as passions and strengths. And I do this with caregivers a lot, pointing out that this obsession that the caregiver may find annoying could actually turn into a strength in the long run. And so reframing, like how to look at that, can be really helpful. Including body movement in sessions or allowing for alternate seating. I've had many sessions where I'm sitting on the floor with the person, or they're completely laying on the floor and fidgeting, and I'm talking in my chair. So again, just being very flexible with that, not being too rigid about social norms or expectations with what it should look like. Adjusting the room for sensory needs, lights, temperature, drinks and snacks available, what smells are there, masks. So during COVID or during strategic masking time, making accommodations for that when needed. Considering their comfort level with personal space and either needing to be closer or farther apart because of that. Another big one is adjusting time. So because I really encourage open and honest communication about what they may need to process or regulate in that moment, sometimes that means ending session early. You know, I've had plenty of times where we get 30 minutes and then we're done and we need to socially recharge and need to stop therapy for the day. And that's totally okay. And then with working with caregivers, just some things to consider is sometimes our caregivers may also have neurodivergent brains and tendencies. And I've worked with a few families recently where they even go on that journey themselves to explore whether or not they have autism after their child gets diagnosed. And then they end up talking with me about that journey and get a little bit of support with that. And I see that being very liberating for the people who have done that, in feeling like they can understand and empathize with their child better, and then also just understand themselves and know how to support themselves better as well. Psychoeducation specific to their child and their communication style. So kind of going back to the points around communication, that language can sound and look different, and helping the parent really understand and hear their kid. So sometimes even for kids who have more limited verbal language, I'll speak as them, as what I think they may be feeling or thinking, to model that for parents, that all behavior is communication of some sort, and it's giving us information about what's going on, what they're feeling, what they're thinking, and that we can try to interpret that. And give language like for other people around them to interpret that and understand them better as well. Helping distinguish between child development, age appropriate types of things that happen versus what might be related or specific to autism or ADHD or anxiety. That's a common question and topic when working with caregivers. And again, it's just that goal of understanding their child better. Providing hope. So a lot of parents, in my experience, especially when they're newly diagnosed or even not after that, feel very overwhelmed and under-supported by even just their natural social supports. So often, having family members that don't understand or avoid, interacting with them because of that. And then navigating the system can be very overwhelming. So care coordination is a big piece of what we do as well when we're working with families, linking to resources. And sometimes that can be the most helpful. Like when we know about community things happening, for example, there was a local group that did a Mother's Day retreat a couple of years ago, and I sent a couple of my families there, and they came back and said it was life-changing to be able to go meet other moms and have the day to themselves. So being open about that as being part of our role as well, like keeping our eyes open for those resources and telling our families about them as we work with them. So when thinking about when it may be more effective or useful to stay with a current treatment team in an outpatient setting versus when it may be important to refer or transfer to a more specialized type of clinic like CADD, I want us to kind of think about it this way. So what are the primary problems that the family is identifying related to symptoms and then also everything else, right? So we're going to say if autism related symptoms, so social communication needs, the kind of emotional reactivity that can come with it, the sensory needs, the differences in communication or language, if they're the primary barriers to the person's well-being or the family's well-being, where they would really benefit from some sort of behavior approach, so behavior theory like ABA, or working with a clinician like me who's familiar with positive behavior support plans and things like that, or social skill building, then we're going to say, let's think about referring them to CADD. Also, if they have really complex needs or comorbidities, especially like medically complicated, a lot of our doctors are very well versed in working with that. If they have below average IQ or significant differences or needs in communication, we do have the experience in being able to help and support families with that. Or if they're in need of extensive psychoeducation around like parent training, maybe even at certain points of their lives, right? Like when they're first diagnosed, or when they're transitioning from middle school to high school or to young adulthood, then maybe more of an autism specific provider could be useful on the team. Whenever it's a client who has verbal abilities or average to above average IQ and language skills, kind of more able to engage traditionally with those evidence-based models of treatment, then they might be better served with their current team, especially if they have a positive therapeutic rapport with that team. I think sometimes disrupting the team to transfer them out causes more issues. To have to start over with somebody, like start over telling your story all over again and coming up with goals and working, it kind of sets the reset button sometimes. So if a person can be supported with their current team, I'm going to encourage that and then encourage consultation with us if that's something that could be useful, right? If you're seeing progress with the current care that's in place, even if it's slower, I think it's important to continue with that rather than disrupting it to start with a new provider. Or if the other comorbid diagnoses are more of the concern, right? So if the depression symptoms are more of the concern, or the ADHD symptoms are more of the concern, then they could be supported with their current team or with teams specific to that. Like I'm thinking like STAR, for example, if it's a teen who's very actively suicidal. And then we're going to have plenty of cases or experiences where we're not sure, right? We're not sure what the best next step would be, or if adding an autism specific provider on the team would be useful. And so I would encourage communication about that as a team.